So back pain, as we all know, is the leading cause of occupational disability, and is the second most common symptom-related reason for seeing a physician. And 85% of us will experience an episode of low back pain. So these are the usual causes, but what we are concerned about in this talk is the anaesthesis. So these are the usual cases which we see in our OPD, and I'll be discussing how I tackle these cases under local anesthesia. So this is a case, 40-year-old female with pain in the back, radiation to both the lower limbs, walking distance is 30 meters, and a listhesis and stenosis. And you can see these are the MRI pictures. And this is how we position the patient. We started now using dual C-arm, which saves us time. And you see here, giving the local anesthesia, passing the guide wire through the needle. Then the dilator is inserted up top, the working channel. Then we use regular big instruments, some specialized ones, to do a quick discectomy under radiological guidance. And like Dr. Krishnan said, putting the endoscope is optional, and usually we don't find it necessary now. And this is the trial, and then we harvest the graft again under local anesthesia using special trephines. And I prefer to use bone graft because my patients don't afford the biologics. And then finally the cage with the bone graft and some graft expanders is used. And this is all being done under local anesthesia, and you can see that the patient is awake and quite comfortable at that. And then again the Jamshedi needles, the regular way to put the percutaneous screws. Again you can see the patient is awake and under local anesthesia and quite comfortable. The guide wires, the Jamshedi, everything is done under local anesthesia as well. So I'll skip some part of it because everybody is quite well versed on putting a percutaneous pedicle screw. So you can see everything is done under local anesthesia. The screws, the rods, and just before passing the rods, I infiltrate the tract again with the local anesthesia, and the rod is inserted and locked. So this is the final construct under lateral view. This is the final construct under AP view, and these are our scars. Transverse screw incisions I use because they are a little more cosmetic. The rod incision scars, the cage, and the bone graft incisions. And this is the immediate post-op, and the patient is mobilized as soon as possible, as soon as she can tolerate, because we have done the procedure under local anesthesia, so we don't expect a prolonged recovery. So this is the question we generally face: can we do adequate disc preparation? So this is the amount of disc which I have removed, and you can see adequate disc preparation is there, because this trajectory gives us access to a broader part of the disc than the standard T-lift or a P-lift approach. So again, will you crush the exiting route? So I just made a small video of a model to see how this specially designed cage with a tapered nose, as it goes through the Camben's triangle, it just pushes the exiting route out of the way, and as it goes, it just distracts the disc spaces and the exiting route moves away. So it goes in quite well, and the trick is to spend the least amount of time with a big device in that Camben's triangle. So this is a model, not a true representative, and since the patient is under local anesthesia, we know how much pain they can tolerate, they can report the pain, and we don't have problems with neurodeficit and stuff like that. But will this fuse? So another case, 55-year-old male, listhesis L5S1, again did a same approach. So this is follow-up at 1 year. You can see very well holding up at 2 year, and the fusion. Very well fused. You can see bone graft inside and outside has fused quite well. So it is just good enough for one level, or can we do more? So this is a 45-year-old female, listhesis at L3-4, and again L4, L5, and this is a 2-level fusion. Again done all under local anesthesia. Another case, 45-year-old male, pain in the back, listhesis L3, L4, and there's a reduced disc height at 4-5 and 5S1. And you can see the flexion extension views, and everybody would agree this case requires a 3-level fusion. And again, So this is the pre-operative MRI, and I would like everybody to pay particular attention to this. You can see the stenosis there, and we did a 3-level, again, transcambin fusion, and again this is done under local anesthesia. And this is the post-operative MRI, and you can very well see the indirect decompression has taken care of the problem there at all the levels. So another case, so with experience, we've been expanding it to you to other things, such as the 70-year-old male with L3, L4 degenerative spondylolisthesis. Patient came with complaints of low back pain. He had been operated elsewhere in 2016, and you can see this is a well-fused area, and we didn't want to touch this. And he had an adjacent segment disease, a proximal junction problem, and then this is the pre-op MRI. This is the pre-op MRI again, pre-op CT. You can see the well-fused there, and there is no reason to touch the index level. So we just put the cage one level above and just bypassed this entire segment altogether. And this again, surgery was done under local anesthesia. And you can see the post-operative scar of the previous surgery versus what was the footprint of this surgery. So these are results in 66 patients. These are the VAS and the ODI scores. The patients do quite well, and the local anesthesia doesn't allow us to be quite adventurous, and we have a live neuromonitoring from the patient themselves. So this is the anesthesia protocol which I use. So the take-home message, the percutaneous techniques are expanding to include fusions and fixations, as every one of us have been showing, right from thoracic to big cages now. Careful patient selection and thorough knowledge is mandatory, and the indirect decompression can work from the front, so it can work from the back as well. And you always have an option to use the endoscope to do a direct decompression in the cases which require it. So I would invite everybody to join the Cambin Society, where we can discuss these approaches and these cases a little more. Thank you for patient hearing.